Hello, good evening, everyone. Welcome back to my IVF and the European Fertility Society. We are back for our final webinar this year. Don't worry, just final this year. We will be surely back next year. And today we will talk about uterine factor in recurrent implantation failure. And our guest today is Dr. Lyubov Mykhaylyshyn, and she's located in Lviv in Ukraine. So welcome. This is your first webinar with us. Thank you so much for joining, and thank you for your time. I'm sure everyone is quite busy, as this is always a busy time before Christmas, but I'm glad that you are able to be here with us today, and I hope that it will be useful. I'm really sure it will be. Remember that we will start with our presentation on our topic, but right after the presentation, there will be time for your questions. So remember, you can put those in the chat during the presentation or afterwards. It's all anonymous, so I can only encourage you to type the questions and get as many answers as possible. We have around 30 minutes for the questions and answers, so don't hesitate. Dr. Lyubov, thank you so much. It's lovely to have you. I hope you are ready to educate us a bit and, of course, explain how uterine factor how uterine factor can affect pregnancy as well, and how we can manage that when it happens with recurrent implantation failures. So, how are you today? Good to have you.
Fine, thank you. Dear friends, good evening, and it's a great honor for me and a great pleasure to take part in this platform. And with a great pleasure, I would like to discuss with you uterine factors in recurrent implantation failure management. So I would like to discuss following issues: the Mullerian anomalies, mainly partial septate uterus, uterine niche, uterine fibroids, and adenomyosis. The topic of the partial septate uterus has long remained controversial, and even with regard to the very definitions that of what situation we called septate uterus. But when we use ESHRE classification, we usually overdiagnose the situation, and according to American classification, we could miss some of this septate uterus. But the best definition from a clinical point of view is QME criteria, namely the depth of internal invagination of myometrium in the bottom area equal of more than 1 centimeter, we call hemiseptate uterus. Finally, and very recently, American Society of Reproductive Medicine experts updated the criteria for diagnosing of septate uterus, and they almost also agree with QME that the depth of invagination of more than 10 millimeters should be interpreted as a uterus with a septum. But it has to be acknowledged that despite a diagnosis of partial septate uterus, many women will experience normal fertility and pregnancy, and only 25% of women will experience their repeated pregnancy loss or infertility or implantation failure. So there is still a question: why do not all patients with hemiseptate uterus do not have infertility, and why don't all patients with septum have a miscarriage? So the question finally is, are all septums the same? And sure that the answer is not, and there is a significant clinical heterogeneity among septate uterus in length, in septal thickness, in the degree of vascularity, and some other data show that they are different. And the uterine septa in patients, for instance, with recurrent implantation, with repeated pregnancy loss, are more vascularized, and they contain more muscle component than the septa, like with patients with idiopathic infertility. At the same time, uterine septa in patients with infertility is characterized by lower vascularization, predominance of connective tissue, and changes in endometrial receptivity. But the mechanism of implantation failure in case of septum might be mechanical and molecular, like uncoordinated uterine contractions, secondary accession of endometriosis, the decreased like different molecules which are responsible for implantation failure. But what is shown in a recent systematic reviews that the presence of the septate uterus significantly reduces the frequency of clinical pregnancies compared to women without this congenital abnormality. The second conclusion of this systematic review was that the removal of the uterine septum significantly increases the live birth rate. So here you see quite recent and large study published in 2023, which included over probably 1,000 of participants with septate uterus undergoing IVF, and it was concluded that the presence of septum was associated with the history of unexplained infertility, repeated pregnancy loss, and recurrent implantation failure. Interestingly, that the structure of myometrium in uterus is much more complicated than myometrium in heart. So now we discuss the possibility to obtain electrouterogram, something what we commonly use in cardiology called electrocardiogram. That helps us a lot to understand heart function. And possibly in the nearest future, with the help of electrouterogram, we will be able to distinguish different subtypes of septate uterus, and it will help us to identify specific characteristics which will be helpful in predicting a miscarriage, impaired implantation, or other obstetrical failures. So take-home messages like conclusions of this part are as follows: that technical progress has made the procedure of removing the septum easier and safer. But according to the literature, it is advisable to remove the septum in patients with recurrent implantation failure, repeated pregnancy loss, preterm delivery. But there is still a need to develop additional ultrasound markers for assessing vascularization, septal structure, and maybe this electrouterogram for RIF patient will be also helpful. Now let's move to discuss the next uterine RIF factor, uterine niche. With increasing the rate of C-sections, the awareness of the complications after C-section is growing, and a long-term complication of the C-section is a niche caused by incomplete healing of myometrium in the site of the scar. Uterine niche is a depression in the scar after the C-section of 2 millimeters and more, and they might occur frequently after cesarean sections, depending on the technique. In ultrasound examination, up to 50% of niches are not visualized without the presence of the fluid, and the niches in the non-pregnant uterus may be filled with fluid or may not contain this fluid. They can also be asymptomatic or can have some clinical manifestations like discharge or bleeding or cramping, etc. And they can be also, the presence of these clinical symptoms does not correlate with the size of the niche. As up to 50% of the niches are not visualized without the presence of the fluid in the uterus, it is recommended to perform liquid or gel hysterosonography, so like it is shown in this picture. And I would like to share with you a very nice study published in American Journal of Obstetrics and Gynecology, and there were more than 500 of patients who underwent euploid embryo transfer after PGTA. Both women after vaginal delivery and women after C-section were included. And the conclusions of this study was that the frequency of euploid embryo implantation in the cryocycle was significantly higher in the group after vaginal delivery. So important conclusion of this study was that the C-section with or without isthmus cell significantly reduces implantation rate after transfer of euploid embryo compared to women with previous vaginal delivery. The mechanism of implantation failure in the uterine niche are as follows. The content of this niche is embryotoxic, first of all. This negative effect of inflammatory cytokines are similar to the mechanisms of implantation disruption as in hydrosalpinx, and we know about this very well, right? So stagnation of this menstrual blood and mucus in the niche, it intensifies inflammatory changes, and it leads for these impaired uterine contractility and also to impairment of endometrial receptivity. And finally, it can bring us to the difficulties with the embryo transfer. So all of these mentioned above can have a negative impact on the success rate. So there are following options in treating symptomatic niches, like medical treatment, like birth control pills, IUDs with levonorgestrel, but it can be effectively used in women without fertility plans, right? So it is known that surgical also treatment very well eliminates these clinical symptoms and significantly increases the residual thickness of myometrium. And clinical pregnancy rates in IVF after surgical treatment is also nice. So here again, I would like to share with you some other study which show that the incidence of spontaneous clinical pregnancies was significantly higher in the hysteroscopic uterine niche resection group compared to the group without this resection, where it was still observed. So authors concluded that the uterine niche may be associated with significantly lower success rates following euploid single embryo transfer. Now let's move on to the next factor, uterine fibroid. There are a lot of studies that confirm that the negative impact of fibroids on obstetrics outcomes, but their impact on fertility remains still less clear. But anyway, here you see a very large meta-analysis which involved more than 70,000 of participants. And it was shown that the fibroids were diagnosed significantly more often in patients with infertility than in patients with no fertility problems. We know very well that the presence of submucosal fibroids like type 0, 1, and 2 demonstrate significantly like 70% reduction in clinical pregnancy rate. But important question is, do other types of uterine fibroids cause implantation failure? So there are numerous of possible mechanisms why myomas can have a negative impact on fertility. First of all, uterine cavity distortion caused by myoma, abnormal and increased uterine contractility, chronic endometrial inflammation, abnormal local hormonal and paracrine changes, impaired gene expression responsible for receptivity, even histological endometrial changes like micropolyps and polyps, etc. And the presence of myoma, we observe some different endometrial blood supply too. What about intramural fibroids that contact with the endometrium, like FIGO type 3? So we know that fibroids are able to produce biologically active molecules that can have a negative impact on implantation. Like closer to endometrium myoma is, more negative effects it will have. That may explain why the presence of type 3 fibroids, which are in contact with endometrium, we can observe a decrease in implantation rate by 12%, clinical pregnancy by 16%, and live birth rate by 13%. The presence of the type 4, 5, 6 fibroids with 3-5 centimeters in diameter may also reduce the implantation rate by 10% and clinical pregnancy rate by 15%. But I would like again to share with you a very nice study. And here patients with intramural type fibroids were divided into two groups based on the frequency of uterine contractions. And as far as you know, uterus has its own peristalsis. So we can calculate it, and I personally do it in my daily practice. So in usual ultrasound mode, we cannot see these waves. So to visualize them, the video is accelerated, and so we can count and evaluate them like this. You can see here in this video, you can count these waves, you see these waves, and their types are changed during menstrual cycle. But what was shown in this study that, and conclusion of this study was that the decreased pregnancy rate was observed in high frequency peristalsis group caused by intramural fibroids, and maybe some additional data probably are needed for more consistent indications for intramural fibroids treatment. It probably can avoid this recurrent implantation failure, so we would know whom operate and whom not. And take-home messages in this part of fibroids can be as follows: that we mostly recommend myomectomy before IVF in case of 0, first, second, and third type according to FIGO classification. Type 4 it can be operated only in symptomatic patients, like those who have bleedings, crampings, mostly bleeding. Type 5, 6, and 7 fibroids operation is not needed before the first IVF, but myomectomy may be advised in case also of recurrent implantation failure of any fibroids, or with the size of more than 5 centimeters, with the size less than 5 centimeters, but adjacent close to endometrium, so-called junctional zone. The next factor is adenomyosis. So regarding adenomyosis, we have now a consensus of what do we call adenomyosis according to ultrasound features. So now we have like direct signs and indirect signs. It is extremely important from clinical point of view. So that is very nice and recent study about impact of adenomyosis on IVF outcome. And the outcomes are strictly dependent from localization of adenomyotic lesions. So like the presence of adenomyosis features in the junctional zone close to endometrium were associated with more than 3-fold higher odds of miscarriage. Diffuse adenomyosis in the junctional zone and severe adenomyosis raised the risk of miscarriage twice. And at the same time, adenomyosis, which is localized in the outer endometrium, did not impact miscarriage rate at all. So it could therefore be argued that the endometrium and junctional zone and the inner endometrium, all of them play an important role in invasion by trophoblast after implantation. So what's about the treatment and improving IVF outcomes? Now we have more and more confirmations that like downregulation by means of GnRH agonist or birth control pills or aromatase inhibitors like letrozole treatment, all of them reduce estradiol level before embryo transfer, and that is important. What do we know now to improve pregnancy outcomes in women with adenomyosis? So finally, I want to express my sincere gratitude to Armed Forces of Ukraine and to people all over the world who support Ukrainian army to liberate our land from Russian invaders. And I believe that goodness will triumph all over evil, and there will be peace on the earth. And now, dear friends, I'll be very glad to answer all the questions. Hope there will be some of them.
Thank you so much. As always, it's been great to have you, and thank you so much for explaining all the factors that can, interfere. So thank you so much for that. Now, as you mentioned, you are ready for the questions. So anyone, there are some questions ready here, but of course, let me just remind everyone that if you wish to ask anything, this is your time. So Dr. Lyubov is simply here for you to answer your questions. And there are some questions with lots of details, so let me just go to the first one, a bit of a shorter question, general question. So if you can have a look, what is the best method to to rule out uterine factors?
Okay, so I can start my first question, right? Oh, okay.
Yes, you can see it, I think.
Yes, great. What is the best method to test the rule out uterine factors? So first of all, we have like recommendations of American Society of Reproductive Medicine. So for sure, we first of all use non-invasive methods like ultrasound examination. And what is extremely important now to use 3D ultrasound, because anyway, with just usual 2D ultrasound, we will definitely miss these uterine malformations like septate, hemiseptate uterus, unicornuate uterus, etc. So that is important. Also, what does recommend us the American Society of Reproductive Medicine is so-called sonohysterography. And it differs a lot from echosalpingogram, because what do we do in this examination? We just put very thin catheter and just push the fluid. It is extremely useful in case like we don't see clear the cavity of the uterus, because in some of the cases when we see everything clear with three layers of endometrium, with the middle zone, we see definitely. But in some of the cases like adenomyosis and multiply fibroids, so it's sometimes not clear what is coming inside and what is not. So it helps us to be prepared for hysteroscopy after all, because we know that now we see here submucous fibroid, here we see adhesions in this place, or even we can see isthmus cells, so-called uterine niche, which we discussed, right? So this method also helps us. And the third, yes, for sure, method is hysteroscopy, because yes, we do. It is really helpful for proper diagnosis of chronic endometritis, first of all, because we know that there are some Delphi consensus, which was published like a couple of years ago by 40 experts in this field, and they made this definition more deeper. So they added some additional signs, what do we call norm and what we do not call norm. And if we see some places of abnormal endometrium, because not the whole endometrium will be the same, there will be spots of abnormalities. And from these spots, we have to take this sample and to test it, and even to test for this amount of CD138 plus plasma cells to exclude chronic endometritis. And for sure, if we have something to remove, we will do it during this hysteroscopy. And even now, what do we know? That this method is less invasive. We can do it even without general anesthesia, because these cameras are now very thin, and we can easily, without special instruments, we don't need to make the cervix wider. We just go through the cervical channel, we see cervical channel, and even patient can talk with us, and we look properly this uterine cavity. And there is still a controversial question which we discuss in all meetings, reproductive meetings that we have, whether to do hysteroscopy for everyone before the first IVF and or not to do. And frankly speaking, there are like two camps among reproductive specialists. Some of them support to do for everyone, and the next group does not support, like after failed IVF attempt. What do I do in my daily practice if I have the risk factors of chronic endometritis or something was in the past? So I would also recommend for this patient hysteroscopy before the first even embryo transfer, to avoid this first negative IVF attempt.
All right, thank you so much. Thorough answer for sure. So thank you, Hannah. And actually, she has another question. So let me go straight to this one, and we will go back to the previous one. Previous ones, of course, questions. I've seen it. I see them. Don't worry. When is the Ultra 3D conducted in your menstrual cycle, and is saline sonogram same as sonohysterography?
Yes, so 3D we prefer to do like in the luteal phase, or at least at the time when the endometrium is not too thin, because it's easier for better visualization we perform. But anyway, it's frankly speaking doesn't matter so much. What's about another question? Yes, there are different procedures. Sonohysterogram, when we just are examining the uterine cavity, because the difference is that there is no balloon in this catheter. So this fluid just is easily getting out. And when we have a balloon for another type of hysterosalpingogram, right? So we can't see some part of the uterus, at least 30% of it is lost, especially is lost this part where this even isthmus cell can be present. So that is why there are two different types of procedures now. And yes, it's also a very controversial question whether to do it for everyone. Probably not. Anyway, it is recommended by American Society of Reproductive Medicine as the method of examination of patients with infertility. So sonohysterogram is recommended for all of patients, like according to American recommendations.
Okay, brilliant. Thank you. Again, Hannah has a follow-up, so let's stay with this patient, and of course we will go back to the previous ones. I have had MRI in February 2024. Would that not show any chronic endometritis?
No, sorry, but MRI is not the method for the chronic endometritis. Just maybe in a cases of thin endometrium or something like this. But anyway, chronic endometritis is the diagnosis of it is hysteroscopical examination, first of all, with the camera. And the second step is that from some suspicious places, we take the biopsy and we count under the microscope with the immunohistochemical method of examination, we count plasma cells. So these two methods that together they can make a proper diagnosis, but MRI is not a method for making a diagnosis of chronic endometritis.
Okay, thank you so much. I do believe it was really helpful for you in that case, and it's clear now. All right, let's go to our next question from Melinda with lots of details, actually. Let me show you this, okay? So we have been doing IVF using ICSI for last 4 years. I'm now 45, have low ovarian reserve. We have MFI, I'm not sure here. Done 13 egg collections, 11 transfers. We did fall pregnant last year, but miscarriage at 8 weeks after double transfer and saw both fetal poles. Just had a hysteroscopy to rule out fibroids. Found anaerobic dysbiosis, which we are being treated for. Due to our long journey, I decided to ask to do DQ alpha test and found that my husband and I match. What's your opinion on this test? We already take prednisolone 10 milligrams at transfer, but I'm researching LIT, L-I-T, and intralipids. Would value your opinion. Anything you can advise here?
Yes. First of all, what I would definitely advise, I would advise PGTA for aneuploidies, because what is extremely important, what do we know, what do we need to realize that yes, the age does matter. Even if you even compare the success rate of two euploid embryos at the age of 45 and at the age of 35, that will be definitely the difference. Because even with euploid embryo at the 35, we can reach from the one embryo transfer up to 70% success rate. And in 45 years, it is like 45%, like maybe twice lesser. What's about dysbiosis in endometrium? Because what do we see now? That yes, microbiome of uterus is something what we still detect. But what we also see that it can be changed from cycle to cycle. And this proper evaluation of microbiome in the endometrium is still a very big challenge, because it looks like that we anyway go through the cervix, and what we know according to the studies that we still are not making it very properly. But anyway, yes, if we have a signs of chronic endometritis, I would treat it. But first thing what I would definitely do, I would pay a lot of attention on the embryo, because still there is very high risk that the risk of miscarriage, impaired of implantation are still connected with embryonic factor.
Okay. Thank you so much for yet another answer. I hope that helped. If there's anything else you wish to add, you know what to do. Just type this in. And Vladana has another one. What is your suggestion if someone was diagnosed with a Sherman syndrome?
Oh yes, that is a difficult question for doctors too, because we still are looking for different properties how to resolve this problem. Yes, because still a risk how these prevent forming this adhesion. For preventing forming adhesions, we still have a special balloons. We use PRP treatment. Yes, we do love PRP in case of Asherman syndrome, because what is the problem still in this kind of endometrium, that because Asherman syndrome are also different. It depends from what part of uterus, whether the whole part of uterus, whether these adhesions are very like thin or like very, very hard adhesions that we just need to cut with them with the energy. It's still lower success rate. What do we have with Asherman syndrome? But what I do personally do in my practice, PRP, yes, I like it in different types, like in infusion or even by hysteroscopy, to make this injection strictly to endometrium. And what do we see? It really helps. Also, the further, we prepare patient mostly in natural cycles, because what do we see? That corpus luteum, if we have it, if we still have a possibility to have corpus luteum and to have ovulation, so we prescribe also HCG, and it helps to produce by corpus luteum a lot of so-called vasoendothelial growth factor, which is extremely important in this blood supply of this endometrium. And sometimes it works, especially also when we have a good, nice euploid embryo.
All right, thank you so much. There are more questions coming up. I'm reading everything, so don't worry. I'm sure I will just try to show everything, so don't worry. Let me go to the next one that I have here. If I had opened my myomectomy, which led to adhesions and thin lining, but I still have fibroids, would you advise another myomectomy?
Yes, that's a good question. But anyway, we have to realize what types of myomas do you have, what size of them do you have, because what is extremely important, this Vigo classification, we have at least 8 types of different myomas. So we anyway have to pay attention. Definitely, we would recommend to remove myomas which are so-called 0, 1st, or 2nd type. So that is myomas which we called in past like submucous myomas, right? There is still a controversy about third type of myomas. Anyway, American studies show that if this myoma is larger in the diameter than 2 centimeters, and we had failed IVF attempt, so by hysteroscopy, not by laparoscopy, not by open operation, but through the inside of the uterus, we can get inside and we can remove it from the cavity. Because what is also shown that is, if we can do it, we have to do it better from the inside, not from like laparoscopy. I would not recommend to like remove fibroids of 7 type, which are like outer subserosal myomas, right? Just if it has a peduncle, we call like it can turn over this peduncle and it can be a risk of severe pain and necrosis. That would be my answer.
Right. Again, brilliant. So thank you. And let's have a look. Okay. Now, again, a bit of a longer question. So not easy cases for sure, indeed. So of course, let me just show you. Okay. Here. Oh, sorry. This is not it. This is the last part that I wanted to. Sorry, just give me a second because we need to go back to select that question and I will be able to show you this. Sorry, I missed this because it wasn't selected, but don't worry, I have it right here. Just many questions, so
Great, I'm happy. There would be no question.
This is why we are here, right?
Yes, that no interest into the lecture.
Exactly, this is why we are here. And I'm sorry, I just need to, for some reason, I am not able to select it. There's some sort of an issue. But Grainy, this is the question from her. I had stage 4 endometriosis on my bowel and an endometriotic cyst on my ovary and had laparoscopy 2 years ago to remove this, and 8 weeks ago had bowel resection and as had endometriosis in the bowel. Everything looks good. Have had failed rounds of IVF and also failed egg donation. Would this have caused implantation failure? And what are the chances of getting pregnant naturally after all this surgery? And the patient is nearly 44.
Oh, probably it is still a risk to have a natural pregnancy because, first of all, we are afraid of the low ovarian reserve and poor ovarian quality. And anyway, if we had a stage of 4 of endometriosis, so it means that it is deep infiltrating endometriosis. So what we would know definitely that the best way to get pregnant is to make like a lower estrogen level, first of all, or at least so in deep infiltrating endometriosis, we still have problems with the tubes. It's a high risk because we had a cyst in the ovaries, so the function of tubes will be different again. The problem of endometriosis is even if we see ovulation and even if our tubes are great, so what do we need to realize? That even sperm that is getting in, it will move not so quickly as it will move in laboratory or in case without endometriosis, because we still need to remember that it is inflammatory process in the whole organism. So anyway, there will be a lot of still questions and risks. At least we can try to conceive naturally for a few months. But if not, I would strongly recommend, like, first to take the embryos, even after that to downregulate, and only after downregulation to transfer, because more and more studies are coming with a confirmation that downregulation, even with letrozole, we like it. So it helps a lot for implantation in endometriosis.
All right, thank you. Not easy questions, not easy answers for this, for sure. And now we will go for Asherman. We will go back to the question about Asherman syndrome. For someone that has Asherman but is already 45, will a natural or modified natural cycle work?
For some that has Asherman but still 45, will a natural or modified? Okay, yes, that's a good question. Whether modified or natural, there still, we see from Nicholas Mecklin very nice studies that he shows us that there's no difference between like natural and modified. Here we even are talking more about modified natural, because we prescribe here HCG, and HCG here is important not just for corpus luteum, it is important for better producing by corpus luteum different vasoactive factors. In Asherman syndrome, it is extremely important to have these vasoactive factors, because we still don't have them in pills. With only corpus luteum by itself produce like relaxin and some other vasoactive factors, and they are extremely important to act on endometrium. There are very nice Japanese studies showing that they are now thinking about an intrauterine device with these factors that can spread it into uterine cavity, and like in some experimental data they show that it looks very nice. So they are thinking about a commercial way of producing this type of IUDs, to place them for like 2-3 months for spreading these vasoactive factors. So in Asherman syndrome, it looks like that it would be better to have modified natural cycle, or at least to start with the natural, and after like 7 days to prescribe HCG, because HCG strongly stimulates the corpus luteum for producing these very important factors for us.
All right, thank you so much. And again, another question, okay, from the very same patient. So if you have recurring Ashermans, does that mean that the endometrium is no longer functional?
If you have recurring, so anyway, we have to see, because there are different types of Asherman syndromes. Like easy one, we need to look on endometrium. What is the thickness? What is the structure of it? Sometimes I was very glad and successful that after just hysteroscopal removal of these adhesions, it was looking great and the success rate was nice. So anyway, it depends on what is the ability of the endometrium to recover all of this. But what was also really unexpected for us, it is Boris Atta study, and we discussed the study all over the world, because every time we were talking about thin endometrium is bad, the success rate is bad. But every time we compared different types of the cycles with different types of the embryos. And what definitely Boris Atta showed, that if we transfer high quality embryo, euploid embryo, even on a thin endometrium, like 5-6, less than 7 millimeters, but not with like adhesions, huge adhesions, just like Asherman syndrome, it was just thin endometrium. So the success rate was very nice. Embryo can be the same as in a patient with the very nice endometrium, like without thin endometrium. So sometimes we also see that, unfortunately, sometimes egg donation programs, when very nice embryo coming from very young lady, it makes just a miracle. We did not expect that it can be implanted in such bad, poor endometrium, but it still happens. Yes, there would be a risk of different placenta complications like placenta previa, placenta accreta, etc., and even the risk of bleedings during pregnancy and premature delivery and low birth weight. But anyway, it somehow works. So if embryo is very strong, it can even overcome these problems in the endometrium.
Okay. Thank you. Anna has another tough case here for you. Let's have a look. Okay, you see lots of detail, I'm sure. We did already 10 embryo transfers, 4 euploid, 6 good quality blastocysts not tested, 2 implanted 2 years ago. None of the following 4 PGTA tested embryos implanted anymore. We did extensive testing in the uterine side, as well as autoimmune checkup, laparoscopy, hysteroscopy. Everything came back normal. We are trying to conceive since 6 years. I have a regular cycle, no male factor. We are now 36. What are the chances, based on the cases you saw, to succeed with our next and last euploid embryo and/or naturally?
Oh, this is a very nice question because it's very common. What I would recommend here, so we are making some additional tests. There are very nice study coming from Diana Alexandra and Ashley Moffat. We still are talking about NK cells, but in uterus detecting in NK cells is still a big challenge. So we went through the way genetical testing of NK cells. So what do we need to know about? I will just talk about a few reasons that are possible here, right? So it's not a very expensive test. We take a blood and we want to know what type of NK cells do we have. So what do we know? That there are some kind of receptors in NK cells called chemoreceptors, but we found that there are 2,000 various of them. But these scientists, Ashley Moffat, they divided them into 3 types, like weak NK cells, middle and strong NK cells. But their activity also belongs from types of HLA-C genes in main complex of histocompatibility. So I realize this may be complicated, but I'll try to explain. So there may be some situation that a couple, both like a woman and both a man, have such type of C2 genes in HLA complex. And these types of genes will also reduce the activity of weak NK cells. So both of them are healthy, but it's very difficult for embryo to implant because NK cells are important in implantation. They help for the chorion to get inside. So in this case, there one reason I had such a few couples that were trying to conceive many times. Some of them just had failed IVF attempts. Some of them had biochemical pregnancies or even clinical pregnancies, but they lost every time. And we just prescribed them GFC, so-called granulocyte clonally stimulating factor, and also HCG. All of it helps to activate NK cells, and they were successfully delivered. That is one probably part of the cases. The second one, yes, different types of autoantibodies is extremely important. So anti-nuclear antibodies, anti-thyroid antibodies, anti-lupus anticoagulant, cardiolipin, glycoprotein, different types of phospholipid antibodies they are important, but they're excluded, right? Chronic endometritis, we need to remember too that we have to exclude because it also can be a scenario. What do we know from the ESHRE guideline from repeated pregnancy loss? So we know that because it was the case when there were two situations when you twice lost the pregnancy, right? So in this case, we have to follow for the recommendations of ESHRE guideline on recurrent pregnancy loss, repeated pregnancy loss, RPL syndrome. They recommend to test for protein C, protein S, and antithrombin, so-called these inherited and congenital thrombophilia. And also what they write there, that in some of severe cases, when we have lost, because biochemical pregnancy is also a pregnancy, we count it as a pregnancy, so that is why it is a recurrent pregnancy loss, not recurrent implantation failure, right? So they discussed there the option of IVIG, intravenous immunoglobulin. They showed there that even in idiopathic cases, when we excluded everything around, so there can be a losses, and IVIG helps. They write there just 4 cases of losing your baby, right? But you have to keep in mind that sometimes if I was patient have just only one embryo available, right? Because of age, because of etc. So we also discuss this option. What's about intralipids? Yes, they do work, but still they work weaker. And we need to realize that intralipids were started to use for different from some other issues. They like make all medications even that you take, they like keep it in the molecule, and sometimes they can neutralize another medications important that you are taking. So yes, they work too, but still their work is much weaker than we will compare it with like IVIG treatment.
All right, tough one for sure. We did some webinars on this particular issue as well when it comes to KIR and HLA immune issues. But of course, actually, Anna has added that I should have mentioned that me might have done the test you are mentioning. I'm KIR
Yeah.
AA C1, C2. My husband is C2, C2.
Oh, great. Oh, it's interesting. Oh, here you see that you have this interesting option because it's extremely important, C2, C2 and KIR-AA. So in this case, yes, your baby would have a possibility to get one C2 from you and C2 from husband, but there is still a risk that your baby can have your C2 and husband's C2, C2. It's very important. It's worse than a woman will have C2, C2. So in this case, I will think about at least about HCG, because again, HCG is activator of NK cells. We know that even seminal plasma is activator of NK cells. So these even 2 options can be used. But I would recommend granulocyte colony stimulating factor. There's a Scarpellini study coming from late, like 2008, his study came. He also showed the beneficial effect of using this medication in a dosage of 100 units per kilo. So it's little dose. It's much less a dose than that is used in oncology, because this medication is mostly used in oncology in leukopenia patients who use chemotherapy and their leukocytes are very low, so it activates like leukocytes in this case. We still, yes, this question is controversial. So many studies are coming, but in a proper examination, like you showed us here, AA phenotype and C2, I would think about that.
All right, thank you so much. Definitely interesting, definitely helpful, I believe, Anna. And of course, remember that we are here live, but of course, if you would like to get some more details, definitely it's best to just directly connect with Dr. Lyubov and her team at Alternatyva Clinic in Ukraine, and I'm sure they will be able to help even more. In the meantime, we did receive one question about KIR A, B, C1, C1, both. Can it be the problem with implantation?
Frankly speaking, it looks that now, because even if it will be like KIR-BB phenotype, so and C1, C2, but it is not a problem of implantation. That would be some obstetrical and other issues. But generally, it wouldn't be a cause of problem, according to these data that we have right now.
Okay, thank you again for that. And Anna has added the previous question, right? With the complicated cases, we actually used only intralipid, but not yet IVIG and not yet granulocyte you mentioned. So possibly there's a chance it could help, right?
Yeah.
Perfect. Thank you so much.
My pleasure.
Okay, one more question about KIR type. Will KIR type affect implantation of double donor embryos and how to test and treat?
Yes, first of all, we need to, because in donor cycle, it's easier like to choose a donor, because what I would recommend, if you are choosing the donor and you like have KIR-AA phenotype, so I would recommend you to take the donor with C1 phenotype. So in case of KIR-AA receptor, it would be bad like to take the sperma special donor with C2. What's about, yes, there are studies of Diana Alexandra. I'm a big fan of her. Her studies showed that double transfer, like 2 embryos, works worse. It's bad, like better to transfer 1 embryo in case of like when we have a KIR-AA and C2 type. But frankly speaking, from my practice, I did this double transfer because, aged woman doesn't want to make GPGTA, and like low risk to have a chance, and we transferred two in the case of KIR AA and C2 type, and she was successful. And I had because we started to do KIR phenotypes like 5 years ago, and we were first in Ukraine because people even from Kiev, from other parts, were sending us samples, and we tested a lot. I can't say that it's a very frequent case when we have these improper matches, but still we find it in cases when people failed to have a successful attempt. Those who had especially diploid embryos and are young and etc. So I like this like activation of leukocytes, and it helps. But the problem is sometimes that if you have autoantibodies, especially like high anti-nuclear antibodies or some other antibodies, so these types of medications, they also stimulate antibodies. So in these, I had such a very challenging situation. So also be careful. There is a proper solution of this, but you have to add so very carefully to take something another. So, but just be careful in case when you have autoantibodies, in case when you're going to use GCF, granulocyte colony stimulating factor.
Thank you so much again. Let's have a look. Veronica has details as well, so let's see. I send my greetings to you in Ukraine and heartily peace soon. And I received the surprising diagnosis of adenomyosis 6 weeks ago, focal adenomyosis. No doctor had yet determined this. I am now 43. Until then, I had a lot of ultrasounds, laparoscopy, and I saw many doctors on my fertility journey. Now, suddenly, a doctor has diagnosed adenomyosis. Shock for us, we have had 14 embryo transfers in recent years, 2 of them with tested embryos. No doctor has seen adenomyosis in this clinic either. Now we have known this for 6 weeks. How would you proceed before a new transfer?
Well, what's about adenomyosis is a very good question, because it was very controversial diagnosis for decades, And there's a very nice organization, ISUOG. It is International Society of Sonologists, and they did a big job, we have so-called MUSA criteria for adenomyosis. And recently they were updated. So because now at least we have some kind of correlation, because we could not understand whether it have negative impact or it does not, or it has or it does not. And I showed you, probably it was last slides in my presentation, and I shared you this very important study which was published in Fertility Sterility in the American Journal. That it's important to remember, first of all, that there are 3 main signs of adenomyosis when we can say properly that it's definitely adenomyosis. So first of all, there have to be like little cysts, like black cysts in the meiometrium. There have to be like these white lines under the endometrial that are connecting with the endometrium. And the third, it's also these islands of hyperergogenic places. But impairment of implantation, as it was shown in this study, would be if these locations of adenomyosis will be close to endometrium, or at least at inner part of meiometrium. If this case is, so what do we know from Peter Humaydin studies, very nice studies, from Kozolino studies, that in this case, preparation for embryo transfer with down regulation would be beneficial, because for decades there were studies, and even ESHRE guideline about endometriosis, etc., say that it doesn't differ, but yes, it does differ. If we use GnRH agonist, or we even use, according to Peter Humaydin study, just birth control pills without this break, at least month and a half, we add the letrozole, and we give a lot of progesterone, because in adenomyosis we have such situation called progesterone resistancy, because we have inflammation. Adenomyosis is inflammation, and progesterone have to overcome this inflammation. It has to overcome these extra estrogens that are produced in the uterus. So Altogether, down regulation with different medications, birth control pills, letrozole, adding additional progesterone, more progesterone than usual in injections, even per rectum in Europe you have. So it would have beneficial effect in adenomyosis if it really is there.
All right. Thank you so much again for a thorough answer. Let's have a look. Another one, long one. So let's see. Does subserosal myoma of 22 millimeters seem to be a threat for pregnancy? I've had 6 pregnancies, 5 naturally conceived and 1 through IVF, egg donation, and 2 failed implantation. Egg donation, 1 donor for all 3 IVF rounds. I am 49, and hoping to try to make a new embryo with a new doctor. Earlier, this myoma was defined as intramural, growing from 25 to 60 millimeters. During hormonal therapies, we were told it is degenerating. I almost have no cycles anymore. Anything you can advise in this particular?
So I just don't understand, because here it's written that now it is 22 millimeters. But earlier there was a myoma of 60 millimeters, right? But it was removed, as far as I understand, right? Because 60 millimeters.
We were told it is degenerating. If there's something you would like to clear with us, just let us know.
Because if it would be 60 millimeters, yes, I would definitely recommend to make an operation and before the embryo transfer. But if it is subserosal myoma of 22 millimeters, yes, I would not believe that it is that is the risk. But frankly speaking, I had a few cases when we also transferred donor's embryo, from egg donation program, and it was just a myoma, fibroid of 35 millimeters, I suppose, but it was type 5, what we call 5. It is partly subserosal and intramural, right? So, and we twice failed. And just after we removed this fibroid, we got pregnancy at one moment. So we transferred once euploid embryo, no result. Second time we transferred euploid embryo, again, no result. And just finally, when we removed it, we got a result. So yes, this recurrent implantation failed, because how we calculate recurrent implantation failure? If we have the embryo after PGT, so like we say we have at least 65 up to 70% success rate. So it is high, right? So twice for 70% success rate and no result, you have to think a lot about what is the reason, because we checked everything, even including key receptors, anti-lipid antibodies, chronic endometritis, etc. And only removal of fibroid gave us result. But 22 millimeters and subserosal, it's too little. I would not believe that.
Okay. Thank you so much. If there's anything else you wish to add, you know what to do. Let's have a look. Next one is up here. So I've had 2 embryo transfers with donor eggs. They both failed to implant. Both embryos were top quality. I'm currently 42. I'm taking immune treatments for high MK cells. Endometrial thickness was 9 millimeters. I also had a hysteroscopy and came back normal. No issues detected. Pelvic MRI also showed no indication of endometriosis or other issues. Is there anything else we are missing here, and any other areas that we need to explore? Any suggestions to improve the chances?
Oh, yes, that's a good question about what do we call high NK cells, because for NK cells there are so many factors that have an influence, and yes, frankly speaking, sometimes I'll also detect in the blood NK cells, but what do I pay attention? Because we know about so-called NK cytotoxicity. We have different markers of this. There is a nice marker of P46, because it was this P46, it's easy to detect and you can easily remove your blood, because these immunological laboratories, proper immunological laboratories, they don't like to make NK cytotoxicity when you have a transportation of blood. You have just to take it and immediately to do it. What's about very high amount? Yes, I would do believe it is, if it is extremely high, like 25, 30, like CD56, right? 1656. Because sometimes what is also maybe wrong, if we make improper down regulation of NK cells, because some amount of NK cells have to be present. And if you use a lot of prednisolone, too much, we can even harm this implantation too. If we do not have any implantation and we failed again and again, and no HCG positive, like HCG again every time is 0, I do like double transfers. So I don't believe in a window of implantation. We did it so a lot. We used air, we used pinopodiums, and I had a patients like that I've transferred out of window of implantation. They got pregnant. But what do we know now? That good quality embryos, it produce exosomes. So some parts of the embryo, they get outside. And these parts of embryo, like exosomes, these microRNAs, they make this endometrium better. So it have to work, because we know that these genes in the endometriums are so complicated. We know a lot about FOX genes, HOXA group, etc. And sometimes these genes just work improperly and not enough. So what do I see in my practice? What does work? If like I transfer one embryo on the 5th day of the progesterone and another one on the like 7, it's something has happened. So like all them together, it mostly we have like single pregnancy, but sometimes yet it occurs even double pregnancy. But in severe cases, I do it if I see that again and again it failed.
Mm-hmm. Okay, crystal clear. Thank you so much. There are about 4 questions left and we will be finishing for today. So let me go straight to this one. How many months or years does the test last? How often must we repeat the test, especially after 2 implantation failures? My last hysteroscopy and HCG was done in 2022.
And just maybe help me, Caroline, what test is mentioned about?
I believe hysteroscopy here, simply because my last hysteroscopy, Hannah
How many
mentioned, was in
months or
2022.
years does the test last?
Does it has to be repeated? I think that's what the patient means, I believe. But Hannah, if there's anything else you mean, let us know.
The test. After hysteroscopy, right? So if we like, because usually if we find something in hysteroscopy, like we find chronic endometritis, right? So, and we have a lot of plasma cells, like more than 15, 10 highly purified fields. So then after antibiotic, after treatment, we repeat the test, but mostly Pipel test with the aspiration of endometrium to detect whether it's okay. Mostly we does not use twice hysteroscopy because it's a little bit expensive. But in case like we have adenomyosis especially, or endometriosis, and the patient failed to achieve pregnancy, so I usually practice to repeat hysteroscopy again in a year, because in a group of adenomyosis especially, we observe more often these types of micropolyposis, chronic endometritis, because of too high estrogens inside. Or also cases like when pregnancy was lost or something has happened and some bleedings. There is also the group of risk that something wrong can be inside of the uterus, and I would recommend in such case to repeat hysteroscopy, if hysteroscopy was mentioned in this question.
Yeah, I believe so, but of course, let us know. But I do believe it was helpful. Thank you so much. So yeah, we got it right. This is what Hannah meant. Thank you so much. I think crystal clear again. So sorry, I need to go back. Oh yeah, I think we've answered, Veronica, this question. So, oh yeah, here, Belinda has a question here. Would you recommend HCG boosters after embryo transfer to help support implantation, like the day before, day of the transfer, and then again a few days later?
Well, I'm also careful with HCG because, sometimes overactivation of NK cells can be also not so very nice. Because, yes, I do, when I was younger doctor, like 20 years ago, and there was very nice studies coming that using HCG, it makes a high success rate. But I can't say that I prescribe HCG for everyone. Mostly if I prescribe, so I would prescribe it on the day of the embryo transfer and 3 days after, mostly. In case but not more often than once 3 days, because we know that mostly HCG acts for 7 days, mostly. If I would like to support corpus luteum, it can be even once a week.
Okay, thank you so much. Natalia has another question. So, can donated eggs, I believe, right, be injected with my DNA? What percentage would my DNA be? I prefer IUI with open donor by far, but I'm 46, no pregnancies nor miscarriages. I'm very natural, no drugs, no alcohol, no smoke. As you can see, any advice?
As far as I understand, you're meaning here the prenuclear transfer, right? When we
Where it's possible.
transfer, yes, when we transfer, like when we fertilize the egg donor and then we use this enucleated zygote and transfer our own pronucleus inside of it. Frankly speaking, as far as you know, Ukraine was one of the first countries in 2016. The first baby was born in Ukraine, probably at the same year. A doctor from New York who made the same in Mexico. They are simultaneously. But what do we see from this practice that unfortunately it also works better like in 40 years old, but in 46 anyway it works not so good. Anyway, we need to remember that making this procedure, we have some additional DNA from mitochondria. So anyway, yes, there are children from three parents because the part of our DNA is located in mitochondria. So if we use mitochondria from donor, we will have their own DNA, and we add there our parents' DNA from father and from mother. So the first children in US were born, they are probably 17 years old, because first procedure it was just they make like from with a syringe from a part of cytoplasm from donor egg which had a lot of mitochondria, and just push it into own egg. And some children were born, and there were up to 30 children, but we are still waiting what will be like after in 60 years old, whether they will have some additional diseases or not, we still don't know. Frankly speaking, it's still an experimental method, so you need to realize it also.
Crystal clear. Thank you so much. And you can just go to our website and have a look at our previous webinars, because actually we are running a series on mitochondrial donation, and there will be more events coming up next year on this particular topic. So you can go to myivfenses.com. I'm sure you will find it there easily. So I think that now we will go for a final question. Lots of those, so thanks a lot, everyone. But this will be our final one. So would a natural frozen embryo transfer be more helpful for implantation than a medicated one with donor X for a patient who is under treatment for high NK cells?
Oh, frankly speaking, if we don't have any endometriosis or something with adenomyosis, so I love natural frozen embryo transfers because anyway we have much less amount of obstetrical complications, because as far as you know, especially with donor X, we are in high risk of hypertensive disorders, placental disorders, and we have much less bleedings with natural cycles, and also we don't use a lot of medications, which is also important. So frankly speaking, if we have a possibility to make a fresh cycle, natural embryo transfer natural cycle, that's great. What's about natural killer cells? If we want to suppress them additionally, so we just use more progesterone, that's it. So progesterone easily acts on the NK cells. More progesterone, less activity of NK cells. Also with estrogens, the same. If we take a lot of estrogens, these are also have an impact on activity on NK cells. But I would definitely recommend a fresh cycle, natural cycle in the frozen embryo transfer.
Brilliant. As I mentioned, that was our final question. Thank you so much. If you have anything else you wish to add, as I mentioned, just get in touch with Dr. Lyubov and her team at Alternatyva Clinic in Lviv in Ukraine. I'm sure they will be more than happy to help you out. We've done a few webinars, actually also in December with the team, and they were all Excellent. So thanks a lot for your participation. As I mentioned, this is our final event this year. So it's been a great year for the webinars of topics, lots of fantastic presenters. And I'm glad, Dr. Lyubov, you were able to join us this year as well. So thanks a lot. As you can see, there are thank yous coming up your way, of course. Brilliant session, brilliant and informative session. That's all I can say. So thanks a lot, everyone. Before we finish, anything you wish to add?
Frankly speaking, that was it was a difficult day for me, but finally, it was so nice to communicate with you and all of you. I wish good time, successful IVF attempts. I do realize that it is very important for you. I wish that this new year will bring you only positive results, and this next year and this Christmas will bring you this light and this blessing. I wish you all of you good luck, and thank you, platform My Fertility Answers, and you personally, Caroline, that you organized all of this. It was very nice. It was very easy for me, and I really enjoy it. Hope
Definitely.
it was helpful.
Great
I
final
want to wish
session.
you good luck.
Thank you so much. And of course, we will be back, as I've mentioned. So everyone have a lovely, peaceful Christmas and a happy new year. And of course, we will be back. And as always, fingers crossed for all of you. You can go and rewatch our previous webinars. There's been lots of those webinars. I don't even know how many, to be honest, but there will be more for sure. So thank you so much, everyone, for your time. Dr. Lyubov, it was great to have you. Now you will be redirected to our survey, so please let us know what you think about our previous webinars and this particular one as well. We would love to hear from you, and as you know, we want to educate you, but we want to explore all different topics, and we simply want to be here and support you as much as possible. So thanks a lot, everyone. Have a lovely evening, and of course, I will see you back here quite soon, I'm sure as well. Thank you so much. Take care. Bye.
Take care. Bye.